Thank you, Dr. Garima, for the case presentation. I will be resuming with the discussion part of the today's topic proper under the guidance of Dr. Akash sir. As I will be discussing the topic under following headings, that is introduction, herpes virus taxonomy, epidemiology of herpes infections, maternal infection, some terminologies associated with herpes infection during pregnancy, congenital and neonatal infection, how to diagnose a case of neonatal HSV, treatment and prognosis. This slide beautifully depicts the spectrum of neonatal herpes affection. It can range from abortion to stillbirth to intrauterine infection resulting in congenital herpes infection to the acute neonatal disease and chronic infection, the form of neurodevelopmental consequences also. So let us go into introduction of the virus proper. Herpes simplex virus, they belong to the group of herpes virus family. They are double-stranded DNA viruses, a total of 8 subcomponents, and all of them have been known to be associated with the neonatal infection. The most common being herpes simplex virus is type 1 and type 2. The serological distinction is based on the structural component of glycoprotein G present on the surface of the virus. And the seroprevalence rates of herpes simplex virus 1 and 2, they vary widely depending upon the age, sex, race, and geographic distribution. It has been observed that in the Western countries such as North America, South America, and African countries, the herpes simplex virus 2 serotype is the major predominant viruses. Whereas in Asian countries, we have more of herpes simplex virus 1 causing these infections. And maternal, in cases of maternal herpes in Asian demographic profile, herpes simplex virus 2 infections, they have to be shown to recur more commonly than herpes simplex virus 1. The incidence of these infections varies from 3 to 30 per 1 lakh live births. The mode of transmission, totally 3 distinct periods of acquisition have been documented in this group of viruses, that is intrauterine, perinatal, and postnatal. As you can see, intrauterine is a very rare phenomenon. It occurs as low as 5 to 6%, whereas perinatal is the major modality of transmission of these infections, accounting for as high as 85 to 90% of these cases. And postnatal acquisition constitutes 10% of these group cases. First, let us understand the simplex infection in mother. Most common scenario is during the perinatal period, that is during the delivery time. Mother might experience burning sensation, per vaginum, and there might be copious vaginal discharge. On examination, erythematous ulcerations with necrotic bases can be found in these mothers. So conducting an appropriate pervaginal examination is very important step in picking up these cases. Apart from this, majority of the genital infections, that is almost 2/3 of these infections, which have been caused by herpes virus, they are asymptomatic. And in cases of prior history of genital herpes in mothers, the chances of recurrences are 75%, and 14% of these mothers, they will have prodromal symptoms at the time of delivery. It has been found in the study published in NEJM that as much as 0.2 to 0.3% of all pregnant women, they shed herpes simplex virus in their genital tract around the time of delivery, irrespective of prior history of HSV. And in cases of mothers who have already affected with HSV in the past pregnancy, the incidence of viral shedding is 0.77 to 1.4%. So what are the risk factors increasing the likelihood of HSV transmission? The first and foremost important is type of maternal infection. Primary infection, it has got 2 to 3 times higher risk of transmitting these infection to the babies when compared to the recurrent infections because of the presence of transplacental protective maternal antibodies. Second is maternal antibody status. This is more or less goes in hand with primary versus recurrent infection. And third is longer duration of rupture of membranes. The more prolonged the duration of exposure of the infant to the genital secretions, the more is the chances of acquiring these infections. And fourth one is integrity of mucocutaneous barriers. such as delivery interventions such as use of fetal scalp probe or incisions, which can cause skin lacerations or abrasions in the neonate, can in turn predispose them under risk of acquiring these infections. Lastly, but not least, mode of delivery. Caesarean section has been found to be protective against herpes simplex virus infections. So these are the few terminologies characterizing maternal infection on serological examinations and cultures. So we have four different categories. That is, first one is documented first episode of primary infection. Second is documented first episode of non-primary infection. Third is assumed primary or non-primary infection. The last one being recurrent infection. So what is primary infection? Primary, as the name itself indicates, that a mother is affected first time and she is seronegative in the past. So the PCR culture from the genital lesion is positive for either virus, that is, it can be either HSV1 or 2, but the antibody status is negative, that is, she is serologically negative, confirming that this is the first exposure of the mother to this virus. So this constitutes our primary infection. Non-primary infection, in the sense, mother has already been affected with HSV in the past, but not with the same, but with the same serotype. So if your PCR or culture from genital lesion is positive for one category of HSV, and maternal antibodies is negative for the same HSV, but positive for other type of HSV. So this constitutes our non-primary HSV infection. Assumed primary or non-primary infection is when you have only PCR or culture results are available from the genital lesion, and vice versa if the serological status is not known. So this is our assumed primary or non-primary infection. In recurrent infection, both the PCR or culture from the genital lesion and the antibody status, they are both positive for the same category of herpes virus. That is, PCR or culture is positive for either one or two, and if the maternal antibody status is also positive for the same serotype of the virus, then it indicates that the mother is having recurrent infection with the same type of virus. So these are the classification of maternal infection depending on the genital HSV viral type and maternal serology. So moving on to the categories of herpes infection, the congenital herpes infection, virus infection, it is a very rare phenomenon or entity. Only 5% of the infants affected with herpes viruses, they manifest with congenital herpes. The likely scenario or setting will be maternal primary infection or disseminated infection acquired in first 20 weeks of pregnancy. These infants, they have characteristic triad of skin vesicles, ulcerations or scarring, eye damage, and severe CNS malformations, including microcephaly and hydrancephaly. This triad is not present in almost all of the cases, and only 33 to 35% of the people, patients, they manifest with these symptoms. The large category of this disease, that is neonatal herpes virus infection, in Asian demography, it has been found that majority of the cases are caused by HSV type 1. Half of these infants, they are born prematurely between 30 to 37 weeks of gestation, and two-thirds of the term newborns, they have normal neonatal course, that is, they just have an infection but they do not manifest with disease symptoms. One-fourth of these symptoms, one-fourth of these infants who have been exposed, they develop symptoms in the first week of life, and two-thirds by the end of first week. This is the categorization of the neonatal herpes simplex virus infection. Depending upon the system affection, the disease process can be categorized into three divisions. That is localized skin, eye, and mucous membrane disease. That is which has got incidence of 45% and mortality of 0%. Second being disseminated infection. That is multi-organ system involvement with worse prognosis. It has got mortality of as high as 57 to 60%. And the last being CNS infection, manifesting as viral meningoencephalitis with the incidence of 30% and mortality of 15%. So identify, as you can see, the mortality rates are as high as 15 to 60% in neonatal herpes simplex virus infection. So high index of suspicion is must in picking up these cases, and early initiation of therapy is the only thing which can prevent mortality in these patients. Moving on to the first category, that is SEM, that is skin, eye, and mouth infections. They usually manifest during the second week of life, that is day 10 to day 12 of life. Most of these cases, that is 90% of these patients, they have skin in clustered with erythematous places uh, uh, present over the presenting part of the baby, that is in vertex presentation. The face will be affected. As you can see in this slide, the baby is having conjunctival and oral affection with vesicular eruptions. So this variety of herpes simplex virus, it has got best prognosis, and recurrences have been documented in SEM group of subcategory of patients. The differential diagnosis of this dermatological manifestation has already been discussed. Any vesicular eruption in the newborn period should be considered, but high index of suspicion with respect to herpes SCM disease should also be considered. The second category of infection is disseminated disease. It usually presents by second week of life. Patients usually have signs of bacterial sepsis, as any other neonatal sepsis. It has been found that 1/5 or 20% of these infants, they develop vesicles, and almost all major organ systems of the body are involved in dissemination, that is liver, adrenal, your endocrine glands, and your respiratory system. They ultimately, 1/3 of these patients can go on to involve your have your CNS affection also, manifesting in the form of meningoencephalitis. And mortality, that is death, usually occurs by 2 weeks of age in this category of patients. The last category being your CNS infection. They usually manifest in second to third week of life. 60% of these infants, they have associated skin vesicles, and less than half of these babies, they have you can isolate viruses from the CSF in the initial period, but subsequently they can have virus manifestations in the CSF. Viral meningoencephalitis of HSV has got characteristic affection for temporal lobes. Babies might have multiple lesions of cortical hemorrhagic necrosis. So the usual symptoms of presentation of CNS encephalitis is lethargy or poor feeding and irritability with focal or multifocal generalized seizures. MRI in these patients can show bilateral extensive temporal lobe damages, and also affection of cerebellum, brainstem, and deep nuclei. CSF can show mild pleocytosis with neutrophilic predominance. Okay. Moving on to the next part, that is diagnosis. As you can see that herpes simplex viruses, the symptom manifestation of these patients, it overlaps with the most common other conditions, that is neonatal bacterial sepsis. So high index of suspicion should be kept in to pick up these cases. Neonatal herpes simplex virus infection should be considered in differential diagnosis of any neonates up to 6 weeks of age with the following symptoms, that is mucocutaneous vesicles, sepsis like manifesting with fever or hypothermia, irritability, lethargy, respiratory distress, apnea, hepatosplenomegaly or ascites, and with CSF pleocytosis. Any babies with convulsions, conjunctivitis, excessive tearing or painful eye symptoms, focal neurological signs, abnormal neuroimaging, persistent thrombocytopenia, and your deranged liver function tests. Any baby who is persistently febrile with negative blood cultures, not responding to the your usual antibiotics, then herpes simplex viruses can be considered as a very important differential diagnosis. A complete laboratory evaluation of babies with suspected HSV includes performing your CBC, LFT to know your organ involvement, especially ALT, RFT to know the renal status and hydration, eye examination to pick up any evidence of keratoconjunctivitis and chorioretinitis. EG examination, if available, should be performed. The characteristic periodic or quasi-periodic epileptiform discharges, which are focal or multifocal, is characteristic of neonatal HSV meningoencephalitis. In neuroimaging, MRI, if available, is the preferred modality. If not, then CT or cranial ultrasound screening can also be performed. Here is an image of MRI of neonatal herpes simplex virus infection showing focal subacute hemorrhage and inflammation over the frontal lobe. This is the classical temporal lobe affection, destructive lesions on CT in cases of neonatal HSV. So complete workup should be done in these cases. The particular virus per se testing includes three options, that is serological evaluation, viral culture, and polymerase chain reaction. Serological testing is not recommended since transplacentally acquired maternal antibodies can give false positive results. Viral culture, it is the definitive method. Surface swab cultures, CSF, and blood samples should be sent for viral cultures. PCR, that is a polymerase chain reaction, it has got rapid turnover and earlier results can be available with this modality. CSF PCR, it has got sensitivity of 75 to 100% in picking up HSV encephalitis and has got specificity of 71 to 100%. But in the initial period, we should always keep in mind that CSF might yield a negative PCR for HSV. And if there is high index of suspicion in and setting, then CSF can be performed repeatedly and repeat evaluation can be done to pick up these cases. So in a case of suspected neonatal HSV, these are the following sample collection specimens which should be collected to establish a diagnosis. Swab specimens should be collected from mouth, nasopharynx, conjunctiva, and anus, and they should be sent for on in a viral transport media. They should be sent for HSV PCR assay. Specimens from skin vesicles and CSF should be sent for HSV culture and PCR assay. Whole blood sample for DNA HSV PCR and LFT parameters monitoring your alanine aminotransferase. So these are the must samples which should be evaluate specimens should be collected in a case of neonatal HSV. So once we have established a diagnosis of HSV, we move on to the therapeutic aspects. Treatment of neonatal HSV has been evolving, and initially nucleoside analogs were used, that is idoxuridine, cytosine, arabinoside, vidarabine, and acyclovir. The first drug which was used to manage these cases was vidarabine, but the safety profile when compared to the safety profile and toxicity was very high with these drugs. So alternative drug which was considered was acyclovir. So acyclovir currently is the only drug which has been recommended for use in neonates. So what are the indications to start acyclovir therapy? These are the initiate acyclovir therapy. But the first and foremost is virologically proven HSV disease where there is no doubt. Is clinically suspected HSV disease pending viral studies. You can empirically start acyclovir in the cases of sick neonates with high index of suspicion of HSV. The third one being asymptomatic neonates who are at high risk of exposure with maternal genital tract infection. There are initially we began with the low dose acyclovir therapy, that is 30 mg per kg per day in 3 divided doses versus vidarabine. In this comparison, it was found that morbidity and mortality was equivalent, but the ease of acyclovir administration and decreased toxicity made acyclovir favorable therapy. Subsequently, we compared high dose acyclovir with against low dose acyclovir. for the treatment of neonatal herpes. It was found that high dose acyclovir it had got better, much improved survival rate and lesser number of sequel neurodevelopmental sequelae. So right now, high dose acyclovir, that is 20 mg per kg per dose in 3 divided doses, is a standard form of treatment of neonatal HSV, irrespective of any subcategories, that is SEM, disseminated, or CNS encephalitis. This is a slide depicting the survival rate and the dosages. As you can see that at the dosage of 60 mg per kg per day, the number of survived patients who have survived was very high. So this was the rationale for using high dose acyclovir therapy. So what all should be the evaluation done during treatment of babies with acyclovir therapy? Since we all know that acyclovir is nephrotoxic, creatine RFT parameters should be monitored, and dosages should be adjusted in terms and preterms according to the GFR and creatinine clearance. Second, twice a week CBC parameters should be monitored to look for neutropenia. Absolute neutrophil count less than 500 warrants stoppage of acyclovir therapy, and patient should be treated with GCSF. Ophthalmologic and MRI examination should be performed, and in infants with CNS disease, repeat lumbar puncture should be performed after a period of 3 weeks, that is at the end of 21 days, and a negative HSV PCR should be documented. If the HSV PCR is not negative, and the therapy should be extended further by 1 week, and again after 1 week the same cycle should be repeated. Treatment of babies should be continued until CSF PCR is negative. Topical ophthalmic antiviral drugs should be used in patients with ocular involvement in additional to parenteral therapy. This may include 1% trifluridine, 0.1% idoxuridine, or 3% ganciclovir. And rest of the treatment is supportive, that is respiratory support, anticonvulsants, shock management. Depending upon the standard protocols, rest of the treatment should be carried out in these patients. So once after completing a course of acyclovir therapy, that is a recommended duration of treatment of 21 days in disseminated or CNS infection and 14 days in SEM disease. This should be followed by oral acyclovir therapy for the period of 6 months. This was the study published in MEGM, in which they studied the effect of oral acyclovir therapy after completing the standard regimen in SEM and disseminated disease for a period of 6 months. They administered acyclovir at a dosage of 300 mg per square meter of body surface area orally in TDS doses. A total of 74 units were enrolled in this study, in which 45 of the infants were with CNS involvement and 29 with SEM disease. They compared the neurological outcome, that is a mental developmental index of using Bailey's scale of infant development, and they found that infants surviving neonatal HSV disease with the CNS involvement, they had improved neurodevelopmental outcome when they received suppressive therapy with oral cyclovir for a duration of 6 months. So all cases of neonatal HSV being treated with acyclovir should be followed by oral suppressive therapy with acyclovir at a dosage of 300 milligram per meter square of body surface area. Moving on to the next important aspect of this disease, that is prevention. So the group of intervention during the pregnancy includes counseling mother who are HSV seronegative to avoid sexual intercourse with a known HSV seropositive partner in the third trimester. And if treating mothers actively with HSV infection with the 10-day course of acyclovir therapy. IV can be used if mother is having more severe disease. Delivery strategies include performing cesarean section as early as less than 4 hours of premature rupture of membrane, but even some ACOG recommends that even beyond 4 hours, if mother is having genital lesions, cesarean section can be performed electively. So performing elective cesarean section in these patients is a most important delivery strategy. And if there is history of prior genital herpes but there are no lesions, cervical swab should be obtained for culture and maternal serology should be performed to determine new acquisition, and high index of suspicion should be kept in babies. Postnatal strategies include contact isolation, avoiding breastfeeding if breast lesions are present, and mothers who have oral HSV, masking should be practiced while breastfeeding. One of the most important aspect is hand washing and masking of healthcare personnel who are suffering from herpes simplex virus disease. So these are the proven preventive measures in cases of neonate HSV. Now moving on to the last section, that is management of the child born to a woman with active genital HSV infection. American Academy of Pediatrics, they came up with the guidelines, which was published in 2013 on how to manage these group of cohort of babies, and it was reassured, reconfirmed in the year 2018 also. To summarize these guidelines, we have two kind of patients. The first one being a maternal primary or non-primary first episode of infection, that is HSV PCR or culture of genital lesion is positive and type specific HSV1 or 2 IgG is negative. So in cases of mother with primary or non-primary first episode of HSV infection, we should consider offering elective cesarean section regardless of the lesion status at delivery or if membranes are ruptured less than 4 hours. As soon as the baby is born, at the 24 hours of life, 24 hours of life, because to avoid maternal testing from the maternal contamination, so the sampling should be done at 24 hours of life. Swabbing infants conjunctiva, nasopharynx and anus for PCR and culture to determine exposure to HSV. We should collect blood for HSV PCR and serum LFT should be performed. CSF analysis should be done for HSV PCR and cell count and other chemistries should be performed. So if the baby is symptomatic and sick, then initiate acyclovir therapy as soon as possible, awaiting the lab results. So once the lab results are available, depending on the type of neonatal disease, you can treat accordingly. If primary or non-primary first episode infection of the mother is confirmed, but a baby is serologically negative and the cultures are negative, some experts they recommend preemptive treatment with 10 days of acyclovir therapy. But in these patients, a close follow parents should be explained about the rashes, the type of skin rashes, and the type, and they should be asked for close follow up to 6 weeks of age. So this is the first category of patients. The second being mothers who have recurrent infection active at delivery, that is HSV PCR or culture of the genital lesion is positive and type specific HSV IgG is also positive. These patients with mothers with recurrent infection, they have lesser chances of transmitting HSV to the neonates since by the virtue of transplacental maternal antibodies. So they are not at as high risk as primary infections. In this category of patients, we repeat the same procedure, that is appropriate sampling should be done. If the infant remains asymptomatic, we do not start acyclovir. We just educate family on the signs and symptoms of neonatal HSV and ask for rigorous follow-up till 6 weeks of age. Treatment with acyclovir is done only if lab results are positive and if there is signs of HSV infection. So the outcome of neonatal HSV, as you can see that at 60 mg per kg per day of doses, almost 100% of the patients with patient treated, they have normal outcome. In CNS disease, if a combination of 60 mg per kg per day along with a suppressive therapy, it has got 75% of the normal outcome and 5 to 10% of mild to moderate outcome and 20% of the mortality. Whereas in disseminated disease, with the same therapy, up to 80% of the babies have normal outcome, 5% have mild to moderate outcome, and 18% of the babies they have severe outcome. So high index of suspicion and early initiation of therapy is the mainstay of managing these cases. So the take home messages of the topic proper would be herpes simplex virus. The most common period of acquisition of these infections are the perinatal period during the birth. Uh, Obstetricians should keep this mind while performing conducting delivery. Appropriate swabbing of genital lesions, if present, should be carried out by obstetricians. A proper and rigorous history during the antenatal period should always be carried out. High index of suspicion in babies who are having signs of neonatal sepsis and febrile with neurological manifestations or cutaneous manifestations, not responding to your routine antibiotics, standard antibiotics, and negative cultures on blood evaluation, bacteriological cultures. Always keep, we should suspect neonatal herpes simplex viruses and infection, and early initiation of acyclovir therapy improves your outcome in these subgroup of patients. These are my references. Thank you.